get cracking. We're optimistic. We're just about to sign a country hub deal with NHS Education Scotland. So we're looking forward to that, really opening the door for a lot more events and collaborative activity with members and colleagues up in Scotland. Really looking forward to that. So that would be on a similar basis to the arrangement that we have with Health Education Improvement Wales, that's been in place for about 18 months now. Has been fantastic partnership. So I'm just kind of letting you all know that that's in the offing. We're expecting to hopefully get some good news on that next week.
Good. Who's your contact for that, John? Is that Kevin Kelman?
Say that again, sorry, David.
Who's your contact for that in NES? Is that Kevin Kelman?
I'll tell you now, hang on. It's Jacqueline who we've been dealing with. Just give me half a tick and I'll tell you. So it's Janice Gibson is one of the person who's really been coordinating it with, I think she's Jacqueline, somebody's PA. I'll get the detail for you shortly, David, and let you have it before the end of the call today. I can see we've got David Quo here. Hello, David. Do you want to join me on the spotlit stage?
I think he's just sorting his video out, John, and then
okay, no problem at all. We'll just give it 30 seconds, gentlemen, if we don't mind.
It's looking like David's got technical difficulties.
Okay, not a problem. David, just while we wait, it's Tracy Ashworth Davis, if you know her. She's the Director of Workforce, I think, for Health Education Scotland. Okay, we're going to get cracking, I think. So look, hello, welcome everybody. It's absolutely lovely to have so many of you on the call. This is always a very popular special interest group within the Institute of Health and Social Care Management. For those of you that don't know me, my name is John Wilkes, and I have the absolute privilege and pleasure of being the Chief Executive of the Institute. We can see I've got lots of people who we know very well on the call this morning, including the chair of the Digital Technology Special Interest Group, David Quo, who's invited me just to kick things off while he gets his video and so on sorted out. Today, it's real focus on Scotland today. We have Professor David Lowe, who's Clinical Director of the Scottish Health and Industry Partnership, SHIP for short. He's also Consultant in Emergency Medicine at NHS Greater Glasgow and Clyde. And we have Paul McGinness. Paul, lovely to see you. Paul is CEO of Lenus Health. And we're going to be discussing Transforming NHS Scotland with new collaboration between NHS research and industry. This is going to be fantastic. Really looking forward to it. I can see we've got David with us now. Do you want to say a couple of words, David, of hello and introduction?
No, I think I'm good. I'm really looking forward to this session. Sorry about my tech issues, but yeah, really looking forward to it. Thank you.
Not at all. All right. Well, I'm going to hand straight over in that case to David and Paul. We're looking forward to your presentation, guys, and thanks so much for giving a little bit of time to the Institute to enable this to happen. We really appreciate it.
Thanks, John. I'll just quickly share my screen now. And thanks for the introduction. Yes, my name is Paul McGinness. I'm the Chief Executive of Lenus Health. And let me just share my screen shortly. You should be seeing that now. So yeah, today David and I are going to talk a little bit about the Memorandum of Understanding that was signed last year between AstraZeneca, the NHS in Scotland and Lenus Health. And the purpose of that MOU was really to kind of develop new digital pathways that enable kind of earlier diagnosis and earlier treatment, and collect kind of evidence of the effectiveness of those pathways, and then look to how we might scale those pathways across Scotland to address some of the big challenges that we're experiencing at the moment. So David is going to kind of give a bit of background to the MOU and kind of summarise some of the kind of challenges facing the health system in Scotland at the moment, which I'm sure is very similar to what's happening in England. And I'll probably summarise some of the projects that have been commissioned and talk a little bit about some of the structures that have been put in place to enable scaling of kind of digital and AI services once kind of evidence has been gathered and collected. I'll then kind of talk a little bit about some of the kind of challenges that we've witnessed around kind of technology adoption in the NHS and some of the approaches we've taken to address that and drive adoption, and share some results of case studies where we've successfully done that under the MOU. So hopefully it should take around 35-40 minutes, and there should be plenty of time for Q&A in the end. So I'll maybe pass over to you, David, to take us through some of the kind of structure around the MOU and the kind of wider context.
Perfect. Thank you very much, Paul. And Paul, if you just could put on presenter view as well, that'd be great. So thank you very much for the invite, John and David. I'm very happy to present to the Institute. As Paul said, I'm going to kind of walk you through a particular case example of some work that we've done for essentially now 5 years, specifically around about COPD, but both of us are going to hopefully achieve is contextualise that in the wider issues of how do we manage patients with long-term conditions through the period of case finding, identifying those at risk, taking them through into a diagnostic pathway, treatment initiation, titration, and then onto long-term condition management, and some of the digital tools, and equally some of the tools that we've had to develop around about people and workforce to be able to support that transformation process. Paul, next slide, please. So I think it's really important to this is a team game. So while John's introduced me as the Clinical Director for Innovation within Scottish Government, the locus of this activity is around the West of Scotland hub, and CSO, the Chief Scientist Office, funded 3 hubs across Scotland, really with a focus at triple helix working of being able to bring industry, academia and the NHS together to respond to priorities. And part of that, as I'll go on to describe, is around about bringing together expertise, which is in this case often e-health expertise, research expertise, but really thinking about how you co-develop solutions to be able to bring them to development, fruition, and hopefully into business as usual. Next slide, please. I think it's always important to put the disclaimer that I am, as John introduced, an emergency physician working in tertiary quaternary emergency department, but the role is broader than that, and really considering the opportunities of digital health to be able to provide care to patients across Scotland, recognising both the challenges of demographics, deprivation, and equally rurality. And there's a lot of projects we're doing really focused on that, recognising often the health economics often stack up, especially around the provision of services to those individuals with large distances to travel, as well as a very key point as we'll bring on around about sustainability, which is critical to our piece. The other bit is obviously the disclaimer, I have no pecuniary interest in Lenus whatsoever, though I am hold a number of grants from predominantly Innovate UK to provide academic support for evaluation of their solutions. Next slide, please. In terms of motivation, I don't think any of you that open the press, BBC News at any point don't understand the challenges that we currently face around about delivery of care to patients across the board, but particularly the opportunities around long-term condition management. And certainly within the context of COPD, which is the use case we're going to talk about today, is how can we proactively move to a care for these individuals rather than calling a 999 ambulance when their disease progression is such that the treatment that we could have initiated 2 to 3 days before ends them coming up into hospital for doing that. And currently hospitals across the UK and worldwide are really challenged by volume of patients, increasing comorbidity, as well as an ageing population with increasing care requirements. And really, I suppose the thesis both within Scottish Government and other healthcare systems is if we don't use digital, how are we going to respond to long-term condition management and care, given all the other contextual challenges around about workforce and fiscal constraints? Next slide, please. So in response to that, Scottish Government have set up the innovation hubs, which again is around that industry, academia and NHS working effectively together to respond to the challenges that we're facing, recognising that as we develop these solutions from initial feasibility study through to adoption, there's a number of stage gates around about evidence generation to be able to support decision making around about adoption, which is ultimately evaluation, continued development and supporting that industry collaborator to get further investment. And that's a really critical point you've seen in the Scottish and indeed the UK innovation strategy, is that need to build up startups, tech-enabled companies to be able to respond to these challenges and for the health and wealth of the nation. We have put in place some catalyst programs that really seek funding through SBRI and other PCP channels to really stimulate activity in areas of needs and equally build capacity through a fellowship program that really is developing the capability of people within the NHS to be able to work with industry collaborators to develop their solutions. And these hubs are place-based and often theme-based. So for instance, Graham Cummings here from the HISIS, which is the southeast, and they've got a particular focus on frailty, which is coming through strongly now. Next slide, please. And for industry collaborators, it's really clear to be able to define what our offering is in the function, which is really to be able to engage in scope, to be able to do problem ideation, bring through to initiate, develop the solution, but critically for the test beds and innovation hubs is really to think about how do we develop evidence to support clinical validation, and importantly for companies to be able to take them through to market validation to demonstrate that yes, it can work in Scotland and therefore be able to access international markets and scale that through, recognising any company that predicates their business and just selling to Scotland is going to be particularly challenged. Next slide, please. In terms of priorities for us, it will not surprise anybody in this call to see that within government and CSO, those priorities are around about digital health, precision medicine and artificial intelligence. And that's really about leveraging UK industrial strategy money, equally increasingly industry funding to be able to develop businesses in this particular area. Gregor Smith, our Chief Medical Officer, similar to that throughout the UK, is really focusing on sustainability, which is both carbon and cost. Workforce recognising the challenges of the post-COVID era, and inequalities about provision of care across the demographic, recognising particular areas of deprivation that are perhaps challenging for people to access care. In terms of that demand signal piece and the piece that Paul's going to run us through around about COPD, chronic obstructive pulmonary disease, is really about responding to elective waiting lists, optimisation of long-term conditions, and diagnostics both for long-term conditions and cancer. Next slide, please. One example of this, the slides have got, you've got an old version of the slides, Paul, around. One example of this is the AstraZeneca MOU agreement. It's a Memorandum of Understanding, is really working with pharma in this case to understand what their priorities are about their product, there we go, life cycle, and be able to bring together NHS and academic collaborators to be able to understand what the opportunities are to develop these projects, where are the shared priorities, and be able to develop evidence to support both deployment within Scotland, but increasingly to act as an innovation hub to support internationalisation of those product services, and often clinical pathways, recognising that the solutions that we develop is often have a tech component, but are either the lever to transform the clinical pathway, or is really a provocation to be able to understand how that clinical pathway currently works and how you could redesign it based upon provision of different individuals into that. So for instance, swapping out consultant cardiologists through the diagnostic phase with physiologists and specialist nurses, and allowing the cardiologists to really focus on etiology or cause of heart failure at that point of value. Next slide, please. And that's really about answering the hard questions. And really a lot of the work we do is data-driven. It's identifying patients that are highest risk, how are they going to drive future costs, and how do we develop pathways, digital systems, solutions that are going to proactively mitigate risk and demonstrate clinical cost effectiveness and acceptability both to the workforce and importantly to the patients. Next slide, please. And that really speaks to burning platforms. We've got a burning platform around about provision of care, as we've obviously established. We've got one around about workforce, and we've also got one about our digital architecture and how we build upon our current electronic health record systems to be able to respond to those particular challenges and be able to re-architect both at the clinical pathway level, but also within the technical and functional level about how we deliver best value given the current investments. Next slide, please. And that's a recognition really that outpatients, or indeed inpatients for the future, one would argue, can't be predicated on the kind of old HIMSS axiom of old organizations plus new technologies equal expensive old organizations. And how do we really think about transformation, recognizing we have to optimize what we currently have and build upon it, which is really important to work with, I suppose, companies such as Lenus to be able to develop solutions that integrate into our current cornerstone systems. Next slide, please. And that really describes the pipeline of value, is how do we have lots of activity happening in discovery science, phase 2-3 clinical trials, development of new solutions, but how do we recognise those that we can pull through effectively, deploy into the NHS and realise the value of that engagement, recognising similar to the startup culture that we're trying to propagate within Scotland as well. You'll have lots of companies you'll support in that initial phase, and there will be a funneling exercise to those unicorns. But clearly for the NHS, we can't be in the business of only having one unicorn, and therefore we really need to be able to develop a herd of that. That's not pushing that analogy too far. Next slide, please. So we're going to focus on COPD, chronic obstructive pulmonary disease. Next slide, please. For which there's a number of solutions at play, of which the Lenus one is the one we're going to talk around, but really it's around about how do we leverage the data we develop through both GP systems, secondary care systems to understand patients at risk. Some of the driver for this was both an academic interest of myself and Chris Carlin, who's my co-conspirator in a lot of these pieces of work, is recognised as an opportunity to bring technologies around about home non-invasive ventilation and remote monitoring and bring them together to respond to that challenge of let's not crash land a patient with COPD that's been worsening for the last 5 days into the emergency department at 2 o'clock in the morning to stay in the hospital for 5 days. And the figures there that you can see make a persuasive argument of why you start with this condition. Next slide, please. And that unmet need is across all long-term conditions. And we're going to talk about COPD today, but really it's about that provocation and challenge to develop proactive screening tools, support productive and efficient diagnosis, to deliver monitoring that can be adopted by the patients and the clinical service, recognizing there's a cost for transformation, and then enabling virtual follow-up. So again, that proactive care models that allow us to identify those at risk and be able to bring those patients in either for asynchronous digital appointments or, when is necessary, bring them into hospital for diagnostic processes or indeed admission if that's required. Next slide, please. Paul, we should just get a signal, like I could blink twice or something, and you just know that slide.
I've been doing well so far.
So context is really around about emerging roles. How can we develop that data? And that's a well-worn piece that only 3% of the data that we develop is actually used for future care. And that's really one of the challenges, is how do we use more of that data? How do we focus it and manage that fire hydrant to be able to allow the workforce that are often not digitally enabled themselves to be able to respond to those potentially AI insights to be able to identify those patients at risk. And that's really part of the hard process, is developing those machine learning models that are explainable, but critically actionable and actually have an endpoint that actually allows the clinician to do something about it. And COPD is a really great example, as Paul's going to talk about developing models about anticipated care planning and mortality, readmission risk, to be able to optimize therapies to see if you can optimize, and risk of hospitalization within a very short period of time, and how do you collect data, surface that to clinicians that's going to be manageable. Next slide, please. And this is really the final piece, because Paul's going to talk a lot about what we've done, but I think that our context for colleagues in this call is an understanding this has been a long process. So the initial pieces of work we started back in 2017, and we've built upon these, of which the substrate has been a digital service for management of COPD, and then we've layered on devices and AI solutions on top of that, recognizing we've got a really strong foundation of a digital service that both the patients and the clinical workforce have adopted and is now being scaled across both Scotland and the UK and now internationally. And that does allow that platform-based approach to both engage with industry around about platform-based trials to trial new therapies or new devices, but equally then start to allow us to look at those harder challenges around about integration of AI or new medical devices around about diagnostic services. So that I'm going to pass on to Paul, who's going to outline the COPD solution and the wider kind of, I suppose, philosophy of the partnership that we've developed around long-term condition management. Thank you very much.
Thanks, David. As you know, I think it's clear from your talk that digital is a kind of key component of the kind of NHS kind of response to the kind of challenges it's facing at the moment. I guess before we get into looking at some of the specific examples that you referred to around COPD, I thought it might be helpful just to kind of summarize from an external point of view some of the kind of digital adoption challenges that we see within the healthcare sector specifically. To put this in context, you know, I've ran kind of digital transformation programs in pretty much, you know, but maybe 8 to 10 different industry sectors, from financial services, you know, utilities, retail, publishing, logistics, and so on. Healthcare is without a doubt the hardest industry sector to kind of drive digital transformation, and it shares a number of the same kind of issues that you get in other industries, such as, you know, trying to change kind of working practices to adopt kind of technology, a lot of legacy technology estates and so on. But it also has some very unique challenges, I think, and I'm kind of summarizing this slide, kind of 4 of them. You know, interoperability, a lot of people talk about that. The interoperability of data is a kind of major barrier to kind of digital transformation. And certainly in our view, a lot of organizations in the private sector and indeed the public sector have kind of moved away over the last few years from a lot of their kind of core data sets residing in specific systems, and they've moved towards kind of data platforms that can ingest, transform, store, and then serve up kind of core data to different people in the organization and to other systems in the organization. That solves a lot of the data exchange issues that we're seeing in healthcare, and helps, you know, drive kind of digital service creation, because the data exchange is much easier to facilitate. And so I think at the moment where the NHS has a lot of data held in the EHR and a lot of data held in GPs, then to solve this interoperability challenge, and I know there's quite a lot of work going on in this area, but we need to move towards kind of data platforms that then support better data exchange. You know, many of you are aware, medical device regulation is obviously a specific challenge to healthcare. It's often very opaque, sometimes very difficult to navigate. The digital divide is cited pretty much in every conference I go to around as a key thing to consider, and often very, you know, quite rightly, there's a key kind of clinical safety question there. And then the kind of point around partial automation is, do we want our doctors to be augmented by AI, or do you want the AI to make the decision? I think certainly from our research, we're seeing that patients are keen that doctors' decision making is informed by AI, but it's still made by the doctor, and the AI is not making the kind of final decision. So I think these are some specific kind of challenges that we're seeing in the healthcare sector. But I thought I would just take time I had a quick look at some of the recent kind of Ofcom stats around the kind of digital divide. And this is some data just pulled from the recent Ofcom report showing for the UK, and I pulled some data around some of the age groups that we're targeting with some of these kind of digital services, often older, not always, but often older individuals. So to pull out some stats here, you know, smartwatch ownership in the UK for 50 to 64-year-olds is now sitting at 36%, over 65 at 18%. Home internet access for 60-64 is 95%, and over 65 is around 80%, and even lower socioeconomic groups and so on. The home internet adoption is pretty high now, and I have these figures going back kind of 2, 3, 4 years, and you can see the kind of drive in digital adoption over that time period. But I think a word of caution, obviously, is that in the last kind of point there is that even where patients over the age of 65 have internet access. Of those patients who do have internet access, 23% of them are not confident online. So I think while this kind of question around the digital divide is over time is being addressed, I certainly think that the digital literacy of these patients, particularly the older ones, needs to be considered really carefully when developing and designing digital services, and that points to a lot of kind of user research and engagement with those users when you're designing services. In terms of just to maybe add a bit of colour to David's comments around chronic conditions, from our kind of analysis and our kind of look at this kind of area, it's clear from both the kind of US and Europe, there's around about 30% of patients that have a long-term condition, and they currently account for about 70% of total health and care spend. So long-term or chronic conditions represent a significant and growing cost and clinical burden to health systems at the moment. And certainly from our kind of research and our engagement with the NHS, what we are seeing is that care for chronic conditions is increasingly dispersed across different care settings, from the hospital into the community and now increasingly into the home environment. And care is also dispersed quite a lot between different medical specialties, which is an increasing problem because of the growing number of patients that have more than one long-term condition. I guess as a result of this kind of fragmentation of care across these settings, what we're seeing is that the health data that's collected is itself increasingly fragmented and often very siloed, which in turn is leading to a lot of patients receiving a lack of guideline-directed medical therapy, which in turn I think is driving some of the high rates of hospitalisation that David referred to in his slides. And given the well-documented kind of demographic trends, where the population over the age of 65 is set to increase by about 50%, I think in the next 30 years or so, certainly it's our view that kind of transformational models of care are required, and that goes beyond, I think, digitizing current offline care models, which is really the trap that certainly the other sectors we've worked in is the first step a lot of industry sectors go to. They say, this is how we do our service at the moment. Okay, how can we digitize that? Actually, what you should be looking at is say, well, how can we redesign our service to work in a digital age? And that's a very, very different solution often from digitizing the current care model. And so I guess while you're seeing a lot of attention in virtual wards and remote monitoring and even some isolated examples of AI, I think they're useful, very useful indicators of progress. But in most cases, the data is still largely siloed. Patient identification is still very slow, and it's still, in our view, a kind of reactive model of care. So I guess our kind of broad thesis, and this is what we brought to bear in relation to the MOU and some of the work that David alluded to earlier, is that for long-term conditions, there is missing digital infrastructure that's really required to give care teams across different care settings both the data insights, David was pointing there to who are the high-risk patients, the data insights they need, as well as the digital tools to act on those insights and coordinate the delivery of care. So the way we've looked at this is into kind of three different kind of pillars. We see kind of the first one being around kind of diagnostics. So software, we think there's a big play for kind of diagnostic software that kind of helps streamline these kind of diagnostic pathways, speeds up time between appointments, resolves a lot of these bottlenecks we see, and reduces the need for repeat outpatient appointments that often happens, and a lot of unnecessary tests. Also supports this kind of hub and spoke model, as we're seeing with community diagnostic centres, where more testing can be done in kind of community settings, while retaining in some cases the decision making with specialists in secondary care, without having to move the data around and so on. And certainly our view is that diagnostics is a really key point in the pathway to collect very rich structured data on patients, which would allow patients to be then risk stratified to understand who's highest risk, and then also onboarded to virtual models of care. The middle kind of pillars around kind of risk stratification, using machine learning models really to identify patients who we think are higher risk to give care teams kind of who've got very limited resources, allowing them to kind of prioritize the patients that they should be acting on and where they can have the most impact. And the third one is around kind of treat pathways, is really giving care teams tools to kind of coordinate the delivery of care to higher risk patients. And that kind of falls to things like remote monitoring and virtual wards, and really making sure those kind of systems and those tools are designed to meet the needs of both the clinicians and the patients as well. And underpinning that is a kind of data platform, as alluded to earlier, that supports that kind of data exchange across the pathway, and also supports sharing more data with patients themselves directly, which has been long called for. And I guess we see these kind of diagnose, stratify, and treat as really as a kind of self-reinforcing loop. As more patients go through diagnostic pathways, it produces a lot more data to drive risk stratification models. The more inferencing models do, the more likely we are to identify who's high risk and get them onboarded onto treat pathways. And I think when you look at some of the kind of documentation and the academic kind of publications around this area, there's the King's Fund are calling quite strongly for a review of how diagnostics are run in the NHS in the UK. They talked about redesigning patient pathways, making better use of technology, and so on. And that kind of follows to the principles of what the approach we were talking about is about. Redesign these pathways, allow a lot of testing to happen more nearer to the patient to reduce the amount of travel as well, in relation to the point around emissions that David made. Digitize as much of that as possible, collect very rich structured coded data. And also, digitizing these kind of pathways also allows you to test out much more easily some of these very innovative devices that are coming on stream now, which are CE marked and can accelerate kind of time to diagnosis. And so as a result of this, what you can do is obviously create very kind of detailed registries of patients with long-term conditions. And one example of that is a project we did with under the MOU with AstraZeneca and David's colleagues in NHS Greater Glasgow Clyde. This was a diagnostic service for heart failure patients. We did this as part of a kind of clinical study. And it's now been operationalized in a couple more boards and now being considered in NHS England as well. But I guess what we proved with that is that we can improve the efficiency of the pathway by about 150%. So a cardiologist can actually outcome about 25 patients in the same time as they managed to outcome 10 patients in the previous face-to-face clinic model. And we also reduced the time to treatment for patients by around 75%. So getting patients onto therapy earlier, which, as we know, actually improves the patient outcomes. As an example around the AI insights and risk stratification, this is a quote I like from Eric Topol. It's showing what the opportunity is around kind of AI in healthcare. In terms of it giving clinicians a much greater, richer view of an individual's medical data, helps them augment, improve their decision making, and also helps provide recommendations to treatment. Ultimately, just the AI is not making the decision; the AI is augmenting the doctor, the clinician, to make the right decision. And as David said, we've recently, as part of work in Glasgow, and indeed work with a few different trusts in England as well. We put in live and into live clinical workflows two machine learning models that's going to stratify risk of COPD patients. So the first one is around patients' risk of mortality over the next 12 months. And the second is around the risk of hospital admission within the next 3 months. And the point of these risk scores is to give the clinicians the insight they need to in order to then make an intervention. And that intervention is often either a therapy optimization review, or indeed it could be the patient being a candidate for a medical device such as putting onto home NIV, or indeed in some cases we've found is patients being demedicalized because actually the patient was deemed as being high risk, but actually the model is showing them as low risk. So it was an opportunity to actually demedicalize the patient. And this kind of gives a view of the kind of dashboard that the clinicians see. So there's a kind of population kind of view of the dashboard, so the clinicians can see how many patients fall into the different kind of risk categories that exist. And then when you drill into an individual patient, and this is an actual kind of patient. There's no PII on this, and we've permissions to share. This is an actual risk score for a patient in April, which showed that this patient had a 17% chance of kind of mortality in the next 12 months. And down the left-hand side, although it's slightly greyed out, what we call our explainability features. Now, the purpose of these explainability features is really to allow the clinician to interrogate the risk score so that they can understand what is driving this risk score up and what is driving the risk score down. So anything in the dark blue is driving risk score up, and anything in the light blue is driving the risk score down. And from a clinician point of view, that helps them understand and trust the top level risk score. It allows them to interrogate it to make sure it's bioplausible, and then allow them to then go and act on it. And indeed, what we're finding is that the explainability metrics are often helping the clinician understand what the right intervention should be for that patient. Because that's highlighting, for example, that a patient has, in one case, a patient had recovered from cancer 15 years ago, which wasn't well documented, for example, or indeed a patient had respiratory failure relatively recently, and is a good candidate for going on to triple inhaler therapies or going on to home NIV. So this is kind of an example of kind of work around risk stratification that is getting into the hands of the clinicians. And it's not just about the technology. There's no point having these AI insights unless clinicians themselves have the tools to then go and act on those insights. And that brings me to the last kind of part, which is around kind of the kind of treatment pathways and some of the digital tools to support that. The kind of way we see that is that this is really focused on the highest risk patients who are often coming in out of hospital, and where there's a very strong kind of, I guess, cost saving to be had from keeping these patients out of hospital and in the home environment, which is also the patient's priority as well. So one example here, and David alluded to this at the start, is the work we've done around kind of COPD, again, targeting patients who've had a previous admission to a hospital over the last kind of 12 months, and then onboarding them to a digital service where we ask them to provide our kind of symptom diaries on a regular basis. We collect physiology from the patients. For a subset of patients, we also aggregate their home NIV data. And then we aggregate a lot of that data into a kind of clinical dashboard, so that clinicians can have a kind of 360-degree view of the patient and are kind of up to date on what's happening with these higher risk patients. And we ran a kind of clinical study on this called Receiver, which has now been kind of peer reviewed and about to be published, I think, next week, which shows a 54% reduction in respiratory related admissions of patients who were put on this service against patients from a similar part of the health board over the same time period. And we also demonstrated a kind of 4.5 bed days per patient per year saving for each patient onboarded to the service. So when you scale that up, it's around about £6 million per year for 1,000 patients in bed day savings. And again, a very critical point I think here is that that the way, and I alluded to this at the start, we spent a lot of time co-designing this service, not just with the clinicians, but also with the patients themselves. And by co-designing the patient, understanding their levels of digital literacy, understanding the context, understanding the types of devices they're using, we managed to make sure that the service and the digital service patients were using was designed to meet their needs. And that was then borne out by sustaining the number of engagements patients make with the digital service at 3.5 times per week, which was measured over a 12-month period. So I think that user-centered design and so on is a really key thing to both the adoption and success of these types of service. So I guess I'll maybe just kind of wrap up there, and I guess and conclude with, I think there's a lot of really interesting and great technology I think that the NHS is exploring and trying to adopt across kind of digital tools and AI algorithms. But I think we're still in the foothills of this. I think at the moment there's I think the NHS is still sending out millions of letters per year, and there's a huge I think there's a huge journey ahead of us to kind of digitize that. But I think technology can't really be imposed on NHS. I think the NHS and the clinicians and the staff in the NHS need to be collaborators in the design and then the adoption of the technology, and indeed they need to be given the time to do it as well. I think that's me concluded, John. So I think if we have any questions, I think David and I'd be happy to answer them.
That's fantastic, Paul and David. Thanks so much, both of you. Goodness me. I mean, I just kind of feel a bit of a revelatory moment here. You know, I love I don't know whether you can bring it back up again, the slide where you've got a picture of the patient's data against about 20 different criteria. And then a little comment piece next to the side of it saying, just so that you're aware, you know, here's your data based on the AI activity, and here's where we think you might need to maybe do some lifestyle review, that kind of stuff. I just thought that was fabulous. What's the sort? Can I just ask before I open this up to the floor? What sort of time scale are we looking at for patients? You know, when there may be an issue occurring, is this like instantaneous? Is this within a couple of hours, couple of days? What's the sort of?
I'll maybe answer that, and then maybe David can come in. But I guess we have a kind of suite of different kind of machine learning models or kind of AI. And where we're focused at the moment is on things like 12-month mortality, which is ultimately a proxy for risk. I mean, that's just, you know, anyone that's got higher mortality is at higher risk. And then we've also focused on kind of hospital readmission risk over 1 month, 3 months, and 6 months. We do have other models which are focused much more on short-term risk over, you know, 3 to 5 days and so on, but we haven't put them into clinical practice yet because I think well. And this is where we went very quickly when we were looking at this, is actually say, well, if we can just predict that someone's about to have an exacerbation, well, that, you know, that would be great. But actually, I think there's clear signs in the data that patients are deteriorating, and I think it's really important to try and start with giving clinicians and care teams enough time to make that intervention and undertake it, and then prevent that downstream hospital admission before then really move into the kind of just-in-time, you know, immediate intervention side of things as well.
Yeah, I suppose if I could add to that, agreed. I think part of it is about, I suppose, workforce adoption and that kind of mortality model at 12 months that allows people to review that in a timely fashion and have that conversation. It's not an immediate constant demands piece. That allows familiarity to build, confidence to build is really important. And then when you move to this kind of 3-month prediction one, that's really about medicine optimization. This is an at-risk population. What can we do to optimize their therapy? And the third model, as Paul says, is obviously the one that, from an emergency physician point of view, very much motivated to develop, that switches off. But there's actually a recognition, actually models 2 and 3 actually also have that impact. It's just not that near and present impact of saying this person could have pitched up an ED and we've head them off at the path. Recognising again, as we said, the digital service already has two-way messaging and patient-reported outcomes and built into it, so that allows the clinical staff to be able to respond either to the patient recognising they're deteriorating or the signal we're seeing with the PROs. And I think as we move forward with more patients and therefore more data, patient-reported outcomes, wearable data, and the whole non-invasive ventilation physiological data allows us to layer that on top and really look at performance, that recognising that we've got a population with a debilitating progressive disease, and actually proactive and preventative care actually is predicated in models 2 and 3. Thank you.
Wonderful. Thank you, David. Okay, I'm going to open to the floor, I think. Would anybody like to ask any questions or make any observations, opinions? The floor is yours, everybody. Just pitch in. David Quo is the first to raise his hand. David is, of course, our chair of the Digital Tech Special Interest Group at the Institute. David, nice to see you. Do say your piece.
Thank you very much. And thank you very much, David and Paul. That was a really excellent and stimulating presentation, certainly. I guess I have 2 questions. One is about data quality. So, you know, we certainly here in England struggle with the quality of the data that exists in the source patient data, so GP systems, but perhaps more so hospital systems, and trying to take those sources of data and put it into other data platforms such as shared care records, which, as you'll know, is the trend in the UK. Actually, it's the mandated trend in England. And so, you know, we do struggle, as I say, with the quality of the, you know, basic patient data, as you know, largely because users of these source systems, you know, use it in variable ways. So it's both a people and a technical issue. So my first question is about data quality, and the second one is about the treatment pillar that you described. So, you know, again, you know, our experience in England is that, you know, asking the patient's care providers, such as doctors and nurses in hospitals, GPs and community workers in primary care settings, you know, they use different digital tools to treat the patient. And again, they struggle with those tools. And I guess my question to you is, as you roll out your system, you know, your AI-driven system, how do you foresee the clinician and the, you know, the care provider having to use multiple systems to do what they need to do in terms of clinical documentation, prescribing, requesting tests, scheduling? Or is it your anticipation that your system will eventually take over those functionalities as you roll it out?
Yeah, so I'll start, and then Paula, I suppose you can come in specifically against that last point. So I think the first thing is to say is it's predicated upon a digital platform for management of these patients. And we've worked very hard on the co-design piece of working with the clinicians to be able to say, what do you want and how does this work, and improving the user experience, to be able to allow them to manage the patients effectively, and equally generate the evidence. So when you go to another health board, another healthcare system, to be able to say, here's the evidence that responds to the manager's and operational needs around about productivity and efficiency. Here's pieces around about acceptability, both to the patient group and the clinician group, and equally the kind of hardcore evidence generation for the clinicians to be able to say that this is effective. In terms of the pipeline piece, I think we've had to work very hard on that, recognising again the digital platform is the substrate for that, so therefore the clinicians enter the data, as do the patients. Within that platform, recognising that some of the utility comes out from accurate data, but equally we do at initiation use electronic health record source data, for which I suppose the glib response is AI is very good at dealing with heterogeneous data, and we know there's an error rate of 10 to 20% in terms of even that diagnostic piece that requires a little bit of cleaning around about events. And that's really important to recognise. What we have done, I suppose, is integrate those kind of key touch points around about the diagnostic process, clinical review bit, we're able to push that data both into our secondary care system. So there's a PDF structure that allows other clinicians to review that data, which is valued, as well as the structured data sitting within the cloud, and also the letters going out to the GP, community pharmacist to understand what we've done in terms of reconciliation. So I suppose it's close alignment with both clinical and technical workflows, recognition that a lot of work has had to be done on data pipelines to be able to support the AI components, but increasingly, because as patients are onboarded onto the digital substrate service, we've actually good quality data, and recognizing that onboarding piece, if they come to a diagnostic pathway, is much stronger than if we're trying to be able to just onboard a patient that's already got established disease for the last 20 years. And that's obviously an easier process of being able to say, you've got a new diagnosis of COPD, we're going to deeply phenotype you and you onboard you, and then continue to manage you based upon patient reports, outcomes, wearable data, and episodic clinical review. Paul, anything to add?
Yeah, I mean, I think it's a really good point that David makes, that you know, data quality is really a quite a big issue around, and certainly if you want to try and operationalize kind of machine learning models, the quality of the data is really paramount. And certainly if you're creating shared care records on the back of data that's poorly collected, then you know the shared care record is not going to be much use either. So certainly that was a something that we realised a few years back, and it's really one of the reasons why we've gone upstream to look at diagnostics, David, is because that is a key part of the pathway where we can collect very rich structured data on patients. And then that data can then follow the patient through the pathway, can also feed the models as well. And that was kind of one of the key reasons for looking at kind of diagnostics. And in relation to the kind of question around the treatment quality of multiple systems, I think there's a couple of points there. I mean, certainly we certainly don't see our system as being the one system to rule them all by any manner of means, and we see the ability to stream the kind of AI algorithms into EHRs and into kind of other third-party kind of systems and remote monitoring platforms where you just provide an endpoint, provide this data, we'll give you the model and the scores and the explainability features. But I think, the point about kind of clinicians or care workers across multiple settings, I think there is a need for them to have common set of digital tools that they work on. And if they're working on COPD or heart failure or whatever, they need a set of tools that they can work on, and everyone needs to be able to access that, whether in the hospital or at home. But equally, I think in other sectors, people use multiple systems now. They're all kind of browser based and so on, and that's that's just the reality of today. So I expect that will continue.
Thanks, David. I can see Angela McFarlane has her hand up. Hello, Angela. How are you doing?
Hi, thank you. That was really good. I kept getting bumped out of Zoom. So, David, I only caught a quarter of yours. So is this, I know it's been recorded, is it going to be shared? Because there were two colleagues that couldn't make this, please.
Yeah, so this will go out on catch up, as with all of the events that we do within the Institute, and you'll be able to use the link for that to share.
Fantastic. And David, Gary White is our man in Scotland, as I'm sure you know, on ship. So Gary's one who couldn't make the call. What was the call to action at the end of your piece, David?
I suppose,
or was it more just socialising the whole thing?
It's a good question, Angela. I suppose the call to action is really a provocation to decision makers both in healthcare systems and I suppose increasingly in government to say, how else are we going to manage long-term conditions if we don't actively participate in digital transformation? I think that's got to be a really critical point. We've got multiple challenges around the workforce, rising age, comorbidity, constraints and finance, and therefore if we don't develop productive, efficient digital services, optimize interactions and really push towards patient co-management models of proactive and preventative care, there's absolutely no way we can effectively deliver against the challenges we face. So I suppose the call to action is really around about how do we transform clinical pathways, recognizing that we can leverage digital tools to support that process.
And thank you very much, David. And then second question, if I may, to Paul. Great presentation, Paul, and I think we saw your stand at Confed.
All right.
So you're probably just as exhausted as I am, having had 2 days of standing on my feet and 20,000 steps. Yeah, so really great stuff, really exciting. And you mentioned that it's going to be, it's been written up for peer publication, correct?
Yes, so it's just been accepted actually, so it should be published next week. Yeah. So it's in International Journal of COPD, I believe that's the journal that's been targeted
Great.
for it.
And I saw David nodding furiously there. And is the plan to scale this across Scotland?
Certainly, yes. I think, and also I think not just Scotland. I think we have it now. Certain parts of the system live in Hull, for example, and we're also we're talking to trusts in the Midlands and in London as well around adoption of it. So, so there's different there's different parts of the tooling depending on what the problem is we're trying to solve. So if it's if it's waiting times, then we generally will go in with kind of the diagnostics kind of play to say we can streamline this, we can bring down your waiting lists, and we can reduce time to treatment. Or indeed if it's high readmission rates for certain diseases, then we see we've got some tools and some AI insights that can be applied to COPD and in time other conditions as well.
No, that's great. I think Paul, perhaps separately we should have a sort of catch-up conversation, because we've got the interface clinical pharmacist team working across Greater Glasgow as well. So when we were chatting with CSO's office, they were saying, oh, is this the same as the and we were saying, so we'll chat another time, huh?
That sounds good. Yeah,
Maybe you'll pop
thanks,
your
Angela.
email into the chat. That'd be good. Thank you.
Yeah, will do.
Thank you, Angela. Thank you. Okay, we've got about 4 minutes left. Would anybody else like to ask a question at all or make a clarifying point? Just while you have a think about that, I just love the fact that this is a genuinely collaborative project. I just love the way that you've just knitted it all together. I think it's all the better for that. This doesn't even seem like a supplier procurer kind of a relationship. This is more, it just feels the way you've described it as just, you know, good people coming together to create great stuff. And I commend you for that. It's a really refreshing sort of low pressure style of working together that I think is probably something we could all look to and think that's the way to do it. We got any more questions? All right, I'm not going to press people to ask questions. I think that's fantastic. I'm going to shamelessly admit that I did do 4 or 5 screen grabs, Paul. I hope you don't mind when you are in full flow.
No worries.
I will always, as you would appreciate, acknowledge that it's your copyright, but yeah, I hope you don't mind. And we will, as I said to Angela, make this available by way of catch up to all of our members. Many of whom may not have been able to make it today, but that's their problem, not ours, as we say. We'll make it available. The next digital technology special interest group meeting is on the 14th of July, and we are going to be looking then kind of really at integrated care and figuring out where we are in terms of the digital solutions that are currently being applied across integrated care, predominantly in England. For that, we have David Quo, Shane Tickell, and Catherine Dampney, who is Director of Innovation and Transformation at South Central and West CSU, and we may yet have another participant on that as well. I can see that Dio Kilo has got their hand up. Over to you.
Yeah, I would say it's very lovely to be on this platform. Very, very lovely. And to be candid, I really want to commend the slide, very on point. And I love the use of the post-fit analysis, talking about the process of sustainability and the projections. Very nice, on point. But I do have a questions about the area of, you mentioned about the ambulance services and digital application. How does that going to be effective? And I really don't understand that particular part. How would that be effective? Because it's going to be an issue majorly. If I could have a clarity on that.
So I suppose I'll take that, and I suppose, thank you, good question. So I suppose there's 2 points to that. One is around about increasingly in Scotland, we're moving towards being able to give Scottish Ambulance Service access to the electronic patient record and key summary data to be able to support decision making. And for instance, if a patient is on the COPD digital service, then that creates a degree of assurance that you can potentially leave that person at home because they've got a care pathway that is going to be able to respond to it. I think the second piece is, I suppose, again, around about provision of data to Scottish Ambulance Service and be able to enable them to both access the data in terms of the summary and within the electronic patient record, but increasingly, I think you have to make the point that this digital service is around about switching off future demands and be able to move to a proactive preventative care model rather than patients phoning an ambulance at 2 o'clock in the morning. And really what we're trying to be able to do is demonstrate that reduction in length of stay and hospitalizations that lead to a reduction in hopefully ambulances stacked outside my emergency department.
There we go. We are bang out of time. We've got about 30 seconds left. So David, David Quo, would you just like to offer a word of thanks to David and Paul, I wonder, on behalf of the Institute?
Well, I certainly would. Thank you so much. I really think, you know, there's so much value in seeing evidence-based IT, something we kind of tend to forget about. And I just think the cooperation that you've demonstrated between industry and the clinical professions and the health service and the research community is excellent. A model for us to look to going forward. Thank you again so much.
Thanks, David.
Brilliant. Okay, well, look, everybody, have a super weekend. And In fact, Super Month, we'll see you in a month's time if you're only connected with the digital SIG, but there is, as you would expect from the Institute, absolutely masses going on other than digital technology explorations. Do please have a look at the website and your emails, get involved. And we have just launched as well today a new campaign looking at how do we better regulate and improve quality. If you were to start with a blue sky or a blank canvas, what would you do? So you can expect to see more about that in the very near future. That's all, everybody. As I say, huge thanks to Paul and David, magnificent gentlemen. We really appreciate you giving the time for it. Bye-bye.
Thanks, John.
Thanks. Bye.